Start again, please. Yeah.
Okay, 25-year-old woman present to the emergency department with 4 days of pelvic pain, left lower extremity swelling, and worsening shortness of breath. She's saturating 98% of room air. She has no significant past medical or surgical history and has never smoked. The CTA chest demonstrates small non-obstructive pulmonary embolism, and lower extremity venous duplex showed a left femoral popliteal DVT. Vascular surgery is consulted for further management.
Okay. Always the same question. What would you do next? You know?
I would like to complete my history and do full cardiovascular examination. In the history, I will ask about any recent long travel, any history of hypercoagulable disorder, history suggestive of inflammatory or connective this one hypercoagulable disorder. Any previous history of DVT, any history suggestive of malignancy.
But the most important, she's 22 years old. What you asked for, the most important.
History of abortion.
Oral contraceptive. Oral contraceptive, right?
Pills, yeah. Oral contraceptive, yes.
Yeah. Oral contraceptive, yes. All right. So let's see what this said here. So she doesn't take oral contraceptive. She has predisposing or have any predisposing factor. And she has never had DVT. The left thigh and leg are markedly swollen. There's a bubble pedal pulses with no neuromotor symptoms. What do you do next? So, okay, so she has just a DVT. An ultrasound showed, clot in the femoral popliteal vein. So what do you do next?
I will start this patient on therapeutic anticoagulation.
Okay.
And I will send hypercoagulable workup.
Do you admit her, or you can do it as an outpatient?
No, I will admit her for sure. She is for admission.
Why?
She needs observation as she's having DVT with BE. She needs admission, and anticoagulation, and close vital sign observation.
Okay. And you want to treat her with anticoagulant. Do you start with the oral, with the DUAC, or you start with
No, I will start with heparin or Clexane.
For how many days, and when you switch her to DUAC? I mean, DUAC can start in 24 days. Can you just put on Clexane next day, put on DUAC, and that's it?
If she doesn't have picture of DVT and only like isolated femoral DVT, I can start her on DUAC immediately. But if she's having BE and significant iliofemoral DVT, no, I will start with Clexane, keep her for like 3 to 5 days, then switch her on DUAC if she's stable.
Okay. No, it's always advised to use the Clexane at least for 5 days. It doesn't matter if she has a PE or not, because Clexane has anti-inflammatory effect also. So it's always advisable to give her Clexane for 5 days, then she have to DUAC, 3 to 5 days. Okay? So don't just about on DUAC next day and that's where stop Clexane. Clexane at least should be 3 to 5 days. And most people, they like to quit for 5 days. Then you switch her to DUAC. Even if you treat patient as an outpatient, you can still give her Clexane as an outpatient and tell her to switch to DUAC after 5 days. All right?
Okay.
So you can treat her as femoral popliteal DVT. But why don't do thrombolysis? She's 22 years old. I mean, do you think should give her thrombolysis or not? Or she's young,
Yes, he is young, but she doesn't have any picture of phlegmasia or impending venous gangrene.
Okay.
And the thrombolysis, the only benefit that it will prevent the severity of the post-thrombotic syndrome.
Okay. And this is for DVT where?
In the iliofemoral.
Iliofemoral only, correct?
Yeah.
So there's no place for thrombolysis or mechanical thrombectomy for popliteal femoral DVT. Only in iliofemoral, correct?
Yes.
So, and she's 22 years old and she's young. She'd be candidate for thrombolysis or mechanical thrombectomy if she has an iliofemoral DVT, correct?
Yes.
So the question for you is that did we rule out iliofemoral DVT in this case, in the picture they
No,
gave to you?
no, we need to do
No.
CT venogram, abdomen.
Okay. So before that, is any indirect sign you look at the ultrasound, you can tell you which is iliofemoral DVT?
Yes, you can look in the femoral and external iliac if
Correct.
there is loss of respiratory phases.
Okay.
That will
Then
suggest proximal obstruction.
it's very important. So what will be next step is to review the ultrasound, because you see the people, they don't give you that, they just give you DVT in femoral vein. But for you, it's very important to see if any variation with the respiration, So it's very important to review your duplex ultrasound to look to see any variation during respiration, or you do it by yourself. Okay, because if you have an absence of the respiratory changes, then you're looking for more proximal DVT, then you may have to go and do CTV, okay? CT venous ultrasound.
Yeah.
Okay.
Okay.
So this is an important. So what do you do next? So again, before we presume, have to be sure it's not iliofemoral. Young. If she's like an 80 years old, I don't care, because she's not candidate for thrombolysis, and she's not phlegmangia. So, but 20 years old, young female, I think she's a good candidate for thrombectomy, mechanical or thrombolysis if she has iliofemoral, only if she has iliofemoral. So what characteristic we look for it? As we said, what characteristic we said? We look for it
Loss of
on the
respiratory phases.
ultrasound. Okay.
Yeah. For acute DVT, you mean?
Now, when you look at now, yeah, in this case, when you review the CAT scan, you're looking for the echolicity of the clot, the size of the vein, correct?
Yeah,
The compressivity of the vein,
compressibility,
right?
echogenicity of the vein,
Respiratory facility of the vein. Because again,
Yes.
if you see absence of the respiratory facility of the vein, that means give you more attention. If you don't see respiratory facility, then there's less chance of proximal iliac vein. So most of you don't need CAT scan. Okay.
Okay.
So the clot is echoluscent and non-compressible with a lack of, there's a lack of respiratory facility in the femoral vein. What's your interpretation? As we said, it's more proximal. So what do you do next? Got CTV, right? What did you recommend? CT venogram. Okay.
Yeah.
CT venogram demonstrate clot in the common iliac vein without extension to the IVC with patent right iliac vein. Do these things change your management?
Yeah, this time I will consider thrombolysis for this patient.
Okay.
I will counsel the patient about the risk and benefit.
Okay.
And I will proceed.
And be sure. Okay, and you have to be sure there's no contraindication for thrombolysis, right? What are the absolute contraindications?
Absolute contraindication is upper GI bleeding in the last 10 days.
Okay.
Neurosurgery within 3 to 6 months, or stroke within 3 to 6 months, or recent surgery, or active bleeding disorder.
Okay. Or
intracranial
avenue
malformation. Yeah.
Okay. Or malignancy. So if you increase your risk, then you don't do that. So what you do in situation if you can do thrombolysis?
I will put IVC filter and mechanical thrombectomy.
Okay, but why you put an IVC filter for?
Just protection. If there is anything, will go to the lung.
Okay. I mean, I will not do that, but I don't think it's wrong. It's extra caution. It's okay. You can do it. But the most important to say, I'll put retrieval IVC filter. Very important. Yeah. Don't forget about it. You cannot just put IV filter, So you want to put the mechanical thrombectomy. Okay. I mean, it's not wrong, but I will not do that. There's no indication. Nobody showed that you need to do mechanical to put IVC filter, especially it's only in the iliac vein. But again, if you put it, it's not wrong. You can be more careful. So you do mechanical thrombectomy. And really now these days, most people, they go to mechanical thrombectomy from the beginning. Most people don't like thrombolysis because you have to put patient in the ICU, and then the problem with, fibrinogen, you have to monitor BT, BTT, all the mechanical problem with the catheters, bleeding, hematoma. So most people nowadays, they go to mechanical thrombectomy right away, or both. Pharmacological, they give like, TBA, they wait like for 20 minutes inside the clot and then try to aspirate it. Or now, because aspiration become very strong, they could use penumbra, and most people, they do it right away. All right, so you do that. So again, in the exam, you can choose whatever you want, all of them correct, but you just have to justify why you want this one or this one. So if you tell them mechanical thrombectomy, it's okay. If you tell them thrombolysis, it's okay. Just have to describe whatever you do, because it's asking about the dose, how much you give it,
Mhm.
and that's it. Okay. So describe the procedure, which is thrombolysis, right? Okay, so how you do thrombolysis?
So I will start by putting the patient in prone position, access the popliteal vein in
Okay,
prone
but she has,
position. Mhm.
okay, but she has a clot in the popliteal vein, right?
Yeah,
Thrombosed.
it's okay.
I think it's okay, but most people, they may prefer, I mean, for me, it's okay, but some people, they prefer to go to the patent vein, to go from the tibial vein, or you can go from the greater seventh vein, small, lesser seventh vein, because patient in prone position,
Mhm.
Um, so it's up to you, but for me, I think you can go directly, even through the clot, you can go to popliteal vein. And then you put a catheter, okay, and then you advance your wire all the way to
Then
the IVC.
to the IVC.
Okay,
Then I will
and
do venogram.
okay,
Then I will advance Fontaine catheter and
okay,
start with the bolus of TBA, 2 to 5 milligram.
okay,
Then I will wait for 20 minutes. I will run another angiogram. Then I will insert my clot retrieval device, penumbra.
so you're doing mechanical. That's what you're going to do, thrombolysis only. Okay, so you're going to do mechanical,
No, I will do
chemomechanical
mechanical. Yeah,
thrombectomy.
yeah, yeah. For this patient,
Okay,
mechanical.
okay. I mean, no, it's not wrong. If you tell me thrombolysis, I'm not against it. You said I'm not saying it's wrong. It's just a different way to do it. I mean, whatever you tell me in the exam, it's okay. Because thrombolysis is not wrong. She has no contraindication for thrombolysis. You don't want to waste like a lot of money for mechanical thrombectomy, so you still can put thrombolysis and wait. So it's not wrong. But if you tell me also what you tell me also is okay. Okay?
Okay.
But you remember what you told me before, you're going to put an IVC filter. So don't forget that. If you decide that,
Yeah.
now is the time to, so I have to put IVC filter.
IVC filter, I will put it in either from the contralateral popliteal vein or before from jugular axis.
Okay. But why Boviti? I can go femoral vein because
Femoral. Yeah, but because she's
yeah.
bronchus.
You're right. She's wrong, but correct. You're right. Yeah. So you go from, that's why I'm not going to put it because it doesn't make sense to me, but that's okay. So you want to go from Bobitiel and put a filter. Okay. Because very hard to put from jugular with patient prone position.
Yes.
Okay. All right. I mean, you can do it still in supine position. If you go through the tibial vein, you can go through the supine position. Also, is not wrong. You see, it's always different way to do same things. So even if you tell me I keep on supine position, I access posterior tibial vein and then go all the way popliteal, then with my catheter, also it's okay, it's acceptable. But the problem for penumbra, this is too big, so popliteal vein will be too small. Penumbra is huge; it's about 8 French, So most of it, I prefer to go through popliteal vein, as you said. All right, so you did mechanical, so okay, and then you do venogram. And you finish your procedure, right? Let's say you do thrombolysis. How do you thrombolysis?
So I will advance my catheter, multiple
Mm-hmm.
hole catheter like Fontaine catheter, into
Mm-hmm.
the body of the thrombus,
Mm-hmm.
and then connect it to the TBA with a
Mm-hmm.
dose of 0.9 per kg per hour, and connect heparin saline to the sheath for continuous flushing.
Okay.
And then I will
But
send the
why
patient
why
to. Uh-huh.
okay. Why 0.9 at 1 milligram? Why this at 1.9? Just curious.
The recommended dose is between zero point 0.5 to 2 milligram in case of DVT.
Right. So why you decide was 0.9? Choose one.
One.
Anyway, yeah, 0. Anyway, you can per hour, of course, right?
Yes.
Usually in the venous, you need a high dose. So usually I start with a 1 and go up to 2. With the arterial is lower dose 0.5 to 1. This is the way you can tell the difference, you know. So the arterial, you don't need to go more than 1. In the venous, most of it, you have to go to 2. You know, go with the start 1 and then you go from there, because a lot of clot. Unless you do mechanical and there's some only dual clot, then maybe 1 milligram will be enough. And then you give the heparin through the sheath, right?
Yes.
How much you give?
I will give 1 milligram in 500 normal saline, and I will keep
Okay.
it running for the sheath.
So how much you getting? How many heparins you getting per hour through the sheath?
It's like 500 microgram per hour.
Yeah, correct. You get 500 unit per hour, unit, no microgram, unit.
And
So you
yes,
get 500 unit per hour through the sheath. For me, I mean, usually I don't give systemic anticoagulant when you go thrombolysis. This is a teaching. And I was surprised that where I'm work now, they give systemic heparin, you know, with the thrombolysis.
systemic
And I
therapeutic dose.
thought, yes, and I was surprised because this is for me, it's contraindications. But then my surprise, I went there, I Googled it, you know, and I found this, yes, a guideline to give it. So I'm really surprised. This is something new. I don't know. So maybe you have to go and read about it. But I was surprised to see now the guideline said, yes, you give systemic heparin with the thrombolysis, which was for me, it's contraindication before, but maybe
But
things
if she
change,
develop
you
any
know.
contraindication, if she develop any complication
Mhm.
from this, she will be in disaster.
Yeah, but this is the guideline. Go and read a guideline for thrombolysis, and I was surprised to see, because I was going to argue with them, say, guys, why you give it? It's not, it's contraindicated. But I said, let me do some search before. So when I went and searched it, I was surprised to see that, yes, it's some papers showed that trial that you give anticoagulant systemic with the thrombolysis. So again, muscle is something new. Anyway, maybe it's better to go and read about it because things change, you know, so that not be surprised during the exam. But the problem also, if your examiner is from the old, like me, and you tell him this information, he may not like it if it's not updated, you know. So you just have to be careful. Anyway, let's see. How do you monitor this patient during thrombolysis? How do you monitor this patient?
I will send this patient to the ICU. I will send the CBC and fibrinogen and BT, BTT, INR, Q
Okay.
4 hour.
Okay. You do BT-BT-INR only if we decide to give a, but the most important, if you give only thrombolysis, is fibrinogen. It's the most important.
Fibrinogen and CBC, yes.
CBC, correct. The following day, describe your subsequent. So what you do next day?
So I will take her back to the OR or hybrid or angio suite, and I will do angiogram from the sheath, and I will assess if there is any residual thrombus, if you need another 1 day more of thrombolysis.
Okay, so you can go up to 2 days usually. Very rarely you have to go for 3 days, you know. All right, so we did that. How to integrate her afterward and for how long? So after, let's say everything clear now. So what you give her now?
Yeah, before I finish the procedure, I would like to do IVAS for the iliac vein, left common iliac vein,
Okay.
to assess for the possibility of Maytherner. And then I will keep her on antitherapeutic dose of anticoagulation, DOAC, for 3 to 6 months, and follow up her hypercoagulable disorder or CAP.
Okay. I mean, the new teaching before you use 6 months, now 3 months is enough if it's unprovoked. It's provoked. Unprovoked, then you have to look for a reason, you know. She may have to be in longer, you know. Provoked DVT, 3 months is enough. But unprovoked, said it depends on what is the reason. Maybe it has to be on longer period, right?
Yes.
So we have to decide, you know. So you can't tell him, you have to tell him provoked or unprovoked. You have to tell, until now, we don't know. We didn't have any result of the test. So we don't know are we dealing with a provoked and unprovoked DVT. And those and the timing and the links is different from provoked or unprovoked DVT.
Yes.
Okay, let's rewind to the night of your first intervention. The nurse called you in the middle of the night for bleeding around the sheaths. What would you do? Okay. The call middle of the night, some bleeding. What do you do?
I will stop the thrombolysis and
Okay.
I will recheck the last dose of fibrinogen and CBC and send the stat 1 and apply
Okay.
gentle compression to the area
Okay.
and assess.
Okay. And the most important, don't forget the fibrinogen, okay? Because this is the
Yeah.
most common reason, fibrinogen, okay?
Yes.
So you have to do that. All right. There is no expanding hematoma, and the fibrinogen is 80, you see? So from
Mhm.
600. So what you do now, you said you stop the TPA, right? And sometimes you have to get FFP.
Yes.
Let's change the scenario. When you initially examine her in the emergency department, she has massive left lower extremity edema with purplish to the skin, non-palpable beta pulse. She states she cannot feel her touch nor wiggle her toes. What's your assessment and plan? So what we are dealing now with.
This is phlegmasia.
Okay. So what do you do
So
now?
this
Let's say
patient need
change that.
urgent. This patient need urgent intervention.
Okay.
Thrombectomy, urgent thrombectomy intervention.
All right. Or mechanical thrombectomy, right?
Mechanical or surgical? Yes.
Yeah, mechanical or surgical thrombectomy. Okay.
Yeah. Yeah.
And what else are you going to do? Plus what?
Fasciotomy.
Correct. Don't forget that. It's very important because you can, venous, can get really loose, like especially if she lost her pulses, So we are in an advanced situation now. So thrombectomy alone will not be enough. So you have to do mechanical or surgical thrombectomy plus fasciotomy. It's an important. Of course, with anticoagulant, everything. Don't forget anticoagulant and all the things, Describe your approach. So you're going to do surgical or mechanical. Let's say surgical. How do you do surgical thrombectomy? And that's very important, really. I mean,
So
I
I will
never had to
do
do it because very rare, but you have to know how to do it.
left groin exploration, identification of
Mm-hmm.
the common femoral vein,
Mm-hmm.
and doing proximal and distal control and transverse incision.
Mm-hmm.
I will do proximal thrombectomy by using Fogarty catheter,
Mm-hmm.
and I
Mm-hmm.
will use S-Marsh bandage from
Mm-hmm.
the toes to the thigh for distal thrombectomy.
That's very good. Very smart. Why don't you just do Fogarty? Why you have to do this one?
Because
Why
of
just
the
instead Fogarty?
valve.
Correct. So it's a valve system. It's very hard to do thrombectomy from above, So let's say you did that and still no flow coming out. Then what do you have to do?
No flow from
Using
proximal or distal.
proximal from below.
So
Because you squeeze it, still no clot. Some clot came out, but it's not still a lot of clot there. So how going to take it out?
I will put a Fogarty now.
Okay, where? You see, it's an
Uh,
oral exam. That's I'm asking this all question because this was the exam, guys. It's not, because I want to know exactly you're in the OR, how going to do it, what you do it. It's
yeah,
an
I will put
important.
wire. I will advance wire distally, and then I will advance Fogarty over wire. Wire usually can pass through the
But
valve. Yes.
not really, because remember, this is valve full of clot. It's not like an open valve. So imagine the picture is a big valve and full of clot. So possibly this wire is going to go inside this big valve because the valve are open because full of clot. It's not like they collapse.
Mm-hmm.
So it would be very hard from above. Then you have
Yeah,
to do
then
it
it
from
is
below,
different.
right?
Yeah, down. Yes, popliteal exploration
Yeah.
and from
So
down.
not popliteal. No, why go popliteal? It's too far. You just need to pass the wire the other way. So go from the posterior tibial vein, okay, and then you advance the Fogarty all the way up in the retrograde, okay,
Yes.
and then if you have the Fogarty over the wire, then you can put the wire to the Fogarty and then put the Fogarty down and all the way and then do Fogarty.
Yes.
You follow me?
Yes.
So, or if you don't have a Fogarty over the wire, you can tie another Fogarty and pull it down over the first Fogarty. So you can go all the way down. You
Oh.
see, this is another way to
Yes.
do it. I mean, but the best way if you have Fogarty over the wire, you can put the wire from below up and then you put the Fogarty through it, and then you can do operative thrombectomy. If you don't have this one, get another Fogarty, try to tie it with the first one and pull it down. So when Fogarty reach down, then you can open, let it go, and then do mechanical operative thrombectomy. And then you can clean all the scalp, okay?
Yes.
So this is, the two most important things. All right. Let's fast forward a few years. So after a few years, the patient present again with a disabling swelling of her left leg. She was found to have an occluded left common femoral iliac stent. So that means they put a stent. So I'm imagining she has a May-Turner syndrome, as you said, and they put a stent. And now the stent is occluded, and you are unable to re-establish flow through the stent via endovascular technique. Notably, the left femoral popliteal vein segment is widely patent. She asks if there is anything else can be do for her. Okay.
Yeah, we can do veno-venous bypass, Balma procedure with the AV fistula.
How we do that?
You take the saphenous vein in the left leg, and you do the anastomosis on the right common femoral vein, and you do distal AV fistula on the left leg.
Okay. So again, you harvest the right saphenous vein up down to the knee, but you leave the proximal connect, correct?
Yes.
And they turn under the skin, and you go to the other side. You suture to the right femoral vein. I do a small fistula.
Yes.
Why do a fistula for?
To improve the flow, because it is very low.
To improve the flow. All right. What if she doesn't have a vein?
You can use heparin bonded graft.
Then you do a graft between femoral to femoral. Okay.
Yeah.
Again, I mean, I never had to do this kind of procedures because I think it's very rare, but I just read about them. So I don't think you're going to see many of these cases. Because in my opinion, if you put a graft, I think we're going to thrombose later on. Let me ask you a question. The patient, she came to my office, I think last week. She's 25 years old. And during her pregnancy, she developed a DVT. So they put her on heparin, and they found she has severe protein S deficiency. Okay. And she went through pregnancy, is fine. And she's 22 years old, her first baby. And after she delivered, after 3 years, she went to one of the vascular surgeon with a CTV, and he found that she has a thrombosed left iliac common and external iliac vein with possible May-Turner syndrome. What will you do for her?
Yeah, I need to make sure that if I put stent, she need to be careful during her next pregnancy.
No, I'm saying what you're going to treat her. She came to you. She's now, she done her pregnancy about 3 years ago. Her DVT about 3 years back. Okay. She has no leg swelling or complaint, but they did a CTV and they found her, but she has a lot of small vein in the suprapubic area. That's why she went to the doctor, because some vein in the suprapubic area, but she has no leg swelling or pain. But he did a CTV and he found she has external common iliac artery thrombosis with questionable May-Turner syndrome.
Yeah, as long as she number one, we need to do this genetic phenotype testing for a protein S.
She has severe protein S deficiency.
Yeah, if it is homogeneous phenotype, then she need lifelong therapeutic anticoag. If heterogeneous, no need.
Okay.
The second thing is compression therapy, trial of compression therapy, elastic stocking.
Why elastic stocking? She has no swelling. Would you go and stent her?
No, if no swelling, I will not stent her. If not life-limiting swelling, I will not stent her.
Exactly, that's what it is. So what he did, he went there and he stent her. Imagine, she's 22 years old. She has a protein S deficiency. You see, I think for me, this is a crime. because she has protein insufficiency. She is 22 years old, and you go and stent her, and she has no symptoms, you know? So what happened is that next month she came to me now because she's pregnant again, but the stent is thrombosed. Of course, the stent will be thrombosed, you know? And now she is pregnant and she has some swelling in her leg. So what will you do?
You cannot do, I don't know. There is a risk of radiation with any therapeutic intervention to her pregnancy.
Yes, of course, radiation was pregnancy, yeah. But why you want to treat her with the thrombolysis? Why you want to open her stent? Just forget about her. I mean, she already has, I mean, stent should not be done at the beginning. I mean, she has no symptom. Now she has symptoms because of the pregnancy.
But now she's having pregnancy will exacerbate her symptoms and also stent thrombosis.
No, she already stent already thrombosed. And she has to be an anticoagulant regardless of the stent or not. She has protein insufficiency, so she has to be lifelong on anticoagulant, right?
Yeah.
So that's it. You don't need to do anything else. I mean, leave her alone. And after she gets pregnant, after she finishes her pregnancy, to have to reevaluate her. If she's completely asymptomatic, I will leave her alone because when she had the stent, she was asymptomatic. So imagine she went back to her baseline, you know? So just guys, I want the whole idea, guys, you have to be very careful. Don't jump to the stent right away. Any patient, because I see a lot of people, they do CTV, say Turner syndrome, they go on stent. Stent is a headache because when you put stent in a young patient, you commit her for anticoagulant for a long, long time. And you know this stent is going to occlude later on, the venous system. So I will not put stent for Turner syndrome unless the patient has severe symptoms. Even if she comes with a swelling in her left leg, I will not, and she has a Turner syndrome, I will not treat her with a stent. You know, just conservative management because stent is not her best options, especially young people, you know, and she's going to get pregnant. The pregnancy itself is going to compress the stent, you know. So the whole idea, guys, when you see Turner syndrome in young people, unless she has disabling, you know, symptom or swelling, then please don't put stent. Treat her conservatively. It's not like every time you see Turner, go and put a stent. No. If it's DVT, it's different. If she came with DVT and after you finish DVT, you see Turner is different because you don't want to prevent DVT. You go and stent her right away. But this patient, she came after 3 years and she already thrombosed her common and external iliac vein. So, and she has no symptoms. There's no indication to do anything for her. And now, even with thrombosis her stent, there's no indication to do anything for her, okay? I just remember because it just came to me last week. So I just, on the same subject, so I just mentioned it. All right. So she asking if anything else can be done. So what about, we go back to this one. What happened last for what the patient present again? Now she had disabling swelling. Yeah, this one's different. She has disabling swelling. Then you have to try to open the stent. If it's not, you do a vein bypass or a graft. But she has to have a disabling swelling. If just mild to moderate swelling, I will not do anything for her.
Yes.
What venous bypass you perform? You mentioned that. Discover procedure, you did that. Why creating fistula, just to prevent it from rethrombosis. What if the patient had a poor caliber clear 7th vein? You said you use a heparin-bounded graft. Okay, that's good. Did very good.
Thank you.
We'll pass you.
Thank you.
All right. All right. Like a second case. Who's any volunteer? But I don't know who was asked today. Let me see who was asked today. Bara, you pick up somebody.
Hello.
Come on, guys. It's an easy. I'm not questioning your knowledge. We're just discussing. You see, I'm not like.
I am ready.
You're game?
Yeah. If there is nobody volunteering, I'm ready.
No, they have to practice.
Okay, I'll take.
Who's that?
Abdurrahman.
Sama? Abdurrahman. Okay, Abdurrahman. Let's do it. Come on.
Okay.
Yeah, let's have some fun, with these cases.
Okay, 58-year-old man is postoperative day 2 from an open.
Sorry. What happened? Sorry, what happened? Here. Go ahead. Sorry. Yeah.
Okay. A 58-year-old man is postoperative day 2 from an open abdominal aorta aneurysm repair. The nurse calls you because of a NAT. He has had worsening oxygen saturation and is now on 4-liter nasal cannula. The patient has only had sequential compression devices on for DVT prophylaxis because of postoperative bleeding concern. How will you wake him up?
Okay. So we have 58 years old young man. He has an open repair of aneurysm. Okay. Suddenly has a worsened, oxygenation after, surgery with 4 days later. So what do you think? First thing you think about patient after surgery has difficult breathing. What the first thing you think about it?
Pulmonary embolism.
Pulmonary embolism. Correct. So we think about pulmonary embolism, okay? And
Yes.
has only had, even he has sequential compression, doesn't mean he cannot have a DVT.
He can not take prophylactic anticoagulation means.
Yes, I mean, and he has, because he has possible bleeding, so he has a bleeding.
Yes.
So remember that every sentence they give you in the exam it meaning. So he tell you bleeding, he want to tell you don't go for thrombolysis. This is very simple like that. Okay. Yes. This is just the reason why I give you this one. Okay. And he give you his oxygenation is weak. I think he has a PE.
Yes.
He has a quiet compression device for DVT, so he want to direct you to the DVT area. So how would you work him up? What you do? What you do next? So they call you patient difficulty breathing. So what you do? What kind of exam you do?
I will examine the patient. I will check the pulses and lower limb calf pain.
Okay.
Then I will go for a CT pulmonary angiography.
Okay. So you're looking for DVT. You look for any sign in the leg, any swelling, any Hoffman sign, Yes. Also, listen to the chest. Don't forget to listen to the chest. He has a PE. Listen to the chest. Maybe he has a pneumonia. Maybe he has a rails,
Yes.
So don't jump right away. You're vascular. You think also about PE, but maybe he has aspiration pneumonia. Maybe he aspirated during surgery, Right. So you see, in the exam, you have to tell them all the things, Yes, you suspect the PE, but also you have to do. So you order an EBG because EBG can't tell you. You order chest X-ray, and most of you're going to go and ask for PE CT scan. Correct? This is sequential. All right. Let's see what they said here. There has no significant past medical history. Symptoms start suddenly with mild chest pain and shortness of breath. That was mild twice. On examination, he is visibly short of breath with tachycardia and hypotension. You see, tachycardia and hypotension, usually tachycardia and tachypnea, both, when he sees them both, is a sign of PE, And he said tachycardia and hypotension on the meter. This is telling you he started having a right heart strain because he started hypertension, on the monitor. There is a marked swelling of the left leg with painful. The knee with a passive dorsiflexion. So that means has DVT. What do you consider about it and what do you do next? So what do you think is going on with this picture he gave you?
I think patient has signs of DVT as passive dorsiflexion of the pain, and I will go for a CT pulmonary angiography.
Okay, so you are but what you are concerned? Tell me what concern. So you're concerned about has a left leg DVT. And you're concerned he has a massive PE. It's a big PE because you're concerned about the heart, tachycardia, hypotension. Okay. So what I do next? So you can get a CT.
And I will put oxygen saturation. Oxygen.
Okay. Saturation. You do that. You put on oxygen. You put on a mask, of course. Breathing. You get a CT for PE protocol, and the most important, you need to get an echo because you want to see, because he's hypotensive and tachycardia. You have the echo to look at the right heart, right? You want to see if any sign of restraint in the right heart, because this is going to direct your treatment. You see, if there's no sign of right heart strain, we treat PE, as and it was anticoagulant only. But when you see sign, but when you see sign of right heart, strain, then we have to be an invasive. Then we have to do a mechanical thrombectomy or thrombolysis, whatever. Okay.
Okay.
So let's see what we did next. And then, okay, I'm looking for evidence of, no, this is the answer. McConnell sign. You know what McConnell sign? On an echo. So they did an echo and they're looking for McConnell sign, an echo. This is very rare. This is a sign of PE. On the echo on the right heart, what you see the first part of the right atrium, the right ventricle. You see the mid part is not functioning, where the distal part is moving. It's like a weird looking, you know. So first part you see is not move, and the distal part of the right ventricle move, called a McConnell sign. This is a sign of massive PE, you know. Yeah. So what you do next? See an echo. While you are waiting for all these tests be done, patient oxygen saturation dropped to 80 and he struggled to catch his breath. What do you do next?
He is telling that patient is unstable. I will take to the cath lab and I will start thrombolysis. If he thrombolyzes,
I mean, this is okay, but remember his saturation is 80. You see in the exam, everything they are thinking you are there. You know, it's something you do it by yourself as a default, but you don't say it. But you're going to do it. I'm sure you do it. But if you don't say it in the exam, they consider that you're not doing it. Like, I mean, imagine you tell me take him emergency down to that for thrombectomy, right? So I'm going to tell you that his saturation is 80. If you take patient with saturation 80 down to the interventional radiology suite, he will die on the table. Okay. So you have to address first saturation. I have to get saturation above first. So I have to put him on mask or rebreathing mask, or maybe have to intubate the patient, you know, be sure that his saturation is fine, or at least secure his saturation, and then run him as soon as possible down to the cath lab for mechanical thrombectomy. Okay.
Okay.
So it's very important to tell him, at least you try to get him more oxygen. So don't rush him without oxygen, you know. So you tell him, put him on rebreathing mask. I may have to intubate him if saturation does not respond. In the meantime, I move him right away to the cath lab for mechanical thrombectomy or thrombolysis. Can you do thrombolysis with this patient?
No, I think recent surgery, I will
right.
go for.
And he has a problem with the bleeding. So he'll be for only mechanical thrombectomy, right?
Yes.
Yeah. All right, let's see what they said next. Patient oxygen saturation climbed into the 90 with a mask. Oh, okay, so they put a mask, they went up to 90. Now 90 is acceptable. And he feel a bit better. The troponin is elevated. When your troponin is elevated, doesn't mean has MI. This is from right chest, right heart strain, right ventricle strain. EKG showed sinus tachycardia, and echo showed right heart strain. See, this is the most important sign. EVG showed decreased partial pressure of oxygen and increased alveolar arterial gradient. All this sign of PE. And this is important. They may ask about this, what sign of PE, what you see on ABG. Okay, so you have to know that. Usually you see decreased partial pressure of oxygen, you see PO2 go down, but the most important, you see increased alveolar arterial gradient. This is sign of PE. CTB protocol showed a subtle pulmonary embolism. How I interpret this feeling and how what you do next. What you do next, so mechanical thrombectomy, right? So it's going to ask you to describe your procedure, right? If you are done one or three patient, what did you consider? Thrombolysis, we said no. How you treat this patient with mechanical thrombectomy? So how you do mechanical thrombectomy? If the left common femoral vein is full thrombus and non-compressible, while the right common femoral vein is patent. So you're going to go through the right common femoral vein, right?
Yes.
And do you ever see any mechanical thrombectomy for pulmonary embolism?
Oh, to be honest, I didn't see him. I didn't see her.
It's not difficult, really. I mean, you go the wire. I mean, usually when you get the wire, always go by itself to the right ventricle, right atrium, and then go down to right ventricle. And if you need the wire, if you use like hydrophilic wire, it just with the flow will go all the way to pulmonary vein. It just push the wire and go by itself. We used to do like, I don't know if you do Swan-Ganz catheters. We didn't use it here. We used to use a lot of Swan-Ganz before, because before this echo, we used to use a Swan-Ganz called Swan-Ganz catheter to measure the pressure in the right in the pulmonary vein or pulmonary artery. And it's very simple. You just inflate the balloon and let the catheter, and the blood will flow all the way to the pulmonary artery and stay there, and you can measure the pressure. And the same here, you let the wire go, and the wire will go all the way to the right. You go to the pulmonary artery, and then after that, you change it to a stiff wire. Then you put a long sheet, and you get your penumbra, and you start aspirating the clot. Okay?
Okay.
So this is the step of the procedures. And then you do a venogram at the end. Okay, so you are able to remove all the clot, and his vital sign rapidly improve. Is there anything else would you like to do? So after remove this one, what are you going to do?
I will put the patient. I will ask you. Okay, anticoagulation is not possible. Okay, I will put IV filter, IVC filter.
Put IVC filter. Okay, I don't think it's not wrong with an IVC filter.
Because anticoagulation quadrilate is concern of bleeding.
So you're concerned about bleeding, you cannot give anticoagulant. So you put an IVC filter, and maybe you leave him on low dose heparin. Okay, it just makes sense. All right. Let's change the scenario. What do you do if it was an otherwise healthy 40-year-old man who presented to the emergency room with no pertinent past medical or past surgical history, who had hemodynamic instability, nuclear oxygen requirement with an acute femoral vertical DVT, and sudden impulsive DVT with evidence of right heart strain? So they will tell you if there's no contraindication for anticoagulant, you're going to do what? Thrombolysis, right?
Yeah. Yes.
Okay, he's going to tell you, okay, describe my thrombolysis. It's the same. You put your wire, then you put your catheters, and then you put them on thrombolysis overnight. Okay.
Those will differ from the lower peripheral, or the same dose?
No, the same dose. Yeah, the same dose. Yeah. But again, really now people do that. Most people do mechanical thrombectomy, really. But again, some places don't have mechanical thrombectomy. There'll be another options, you know. Let's say you don't have either of them. What you can do? Is any other options? Anybody knows?
Systemic anticoagulation?
No, I mean, his saturation went down. Surgical thrombectomy is an option, yes, if patient is deteriorating. But there is something also less invasive from surgical.
You can do ECMO.
ECMO. Yes, ECMO. That's correct, ECMO. And most people now, they do an ECMO. But of course, if you don't do it, the best way is to remove the clot. This is the first line, you know. But for some reason, if you cannot remove the clot, for some reason you don't have it, mechanical thrombectomy, you don't have thrombolysis, then surgical thrombectomy, they don't have a cardiac surgery service, then ECMO would be the best option. Contraindication for fibrolytic therapy, we talk about it. He has done all of this and has no evidence of concomitant acute coronary syndrome. Workup, what you do? Thrombolysis, we talk about it. What patient with pulmonary embolism would not procedurally intervene on? What kind of patient with a pulmonary embolism we don't do intervention on him? You understand this question?
Patient stable.
Yeah, patient stable and has no strain on the right heart, right?
Right heart strain.
No right heart strain and is stable. Saturation is fine. Then we just treat him anticoagulant, right?
Yes.
Yeah, and then for 6 months, and then we depend on, you know, provoked, unprovoked, any reason, no reason. Then we have to go through all these scenarios. But usually, if it's no heart strain, the only indication for PE really, if you have a right heart strain,
massive unstable.
You have to know the signals, the signs, you know, the right heart strain on the echo. Yeah, what's called McConnell sign. They may ask you about in the exam. And now EBG also very important. The EBG, because this is easier and faster than ECMO. You do an EBG and you see alveolar arterial gradient, increase gradient between the alveoli and arterial oxygenation because of PE. All right, you did very well. You see, it's not difficult. Let's see if we go to the next question. Okay, let's go to the last one. What time is now? Almost 10 o'clock. Any other
Yes, I will take
volunteer?
this case. I will
Okay.
take this case. Yes.
Okay, Osama, let's go.
60-year-old woman referred to the clinic with the wound in the medial left ankle with associated swelling. This wound has been present for over a year, and she is currently seeing a wound care for it. The wound initially improved the department, but the wound care nurse says that it will not completely heal. She's obese, diabetic, and non-smoker. She denies any history of claudication, wrist pain, or pre-surgery. So I will obtain a detailed history and physical examination, and this patient most likely she has a venous ulcer, giving that the location of the ulcer, and she has no claudication or any wrist pain.
Okay. So how do you know the venous ulcer? How can you differentiate venous ulcer from arterial ulcer?
The arterial ulcers usually came in the toes and the foot, and the venous ulcer usually came in the medial and lateral malleolus areas.
What
and
else?
Also by physical examination, you can check for distal pulses, and
But sometimes when you look at the ulcer, just looking at it, you can tell the venous ulcer. So what the features you can look at the ulcer and say, oh, it's a venous ulcer. I mean, the moment I look at the leg, I can tell the venous ulcer.
The hyperpigmentation.
Hyperpigmentation. You can see the whole skin is brown. The ulcer is large. You don't see small, it's very large ulcer. It's superficial. Sometimes it can go deep, but most are superficial. And the most important, the base is hyper, like red, you know, because you have hyper circulation. So usually the base is red, you know, and large, and usually medial or lateral malleolus. You don't see in the feet venous ulcer. Very rare.
Yes.
Okay.
So in this case, I will order for her ultrasound Doppler venous for assessment of the deep and superficial system.
That's correct. So you did focus history. You did that. There's no other patent past medical history. The wound is about 5x5 with a beefy red base and no evidence of infection or drainage. Beta pulse are intact. Don't forget, you need to do an EBI also. Anytime you do a venous ultrasound and you need to treat venous ulcer, always order EBI because we treat them with a compression dressing, right? So if they have an arterial, you know, insufficiencies, make them worse.
Yes.
Which is rarely I see both because very rare to see venous with arterial pathology. Usually you see either arterial or venous. Very, very rare you can see them both. But always to be on safe side, always have to do an EBI in the patient with venous ulcer because you have to put really compression dressing, 3-layer or 4 layers compression dressing. Okay, so the left leg has one pitting edema and some dermatosclerosis with a woody texture. What you do concern about venous ulcer? We said that.
Yes.
The venous duplex showed DVT. Not DVT, but straight deep reflux of the femoral popliteal vein as well as superficial venous vein from saphenofemoral junction to the ankle. There's no reflex perforator seen. EBI are normal. How do you interpret these findings?
This patient, she has superficial venous insufficiency. In such cases, we start with conservative management first by elastic stocking and compression, elastic stocking for 2 to 3 months. Then we will assist the patient if it is improved or not. If she is not improved, we will start for ablation of the superficial system, the great saphenous, as she has a reflux in the great saphenous.
But how's it going to help? Because she has a deep system reflux. So if you treat the superficial, it's going to be enough?
Most of cases, yes, we start with the superficial, we will not treat the deep system.
Why is that? Because no perforator, right? If there's any perforator reflux, he said no reflux. So it does not the deep venous, the reflux, the deep venous system will not affect superficial venous system unless if you have incompetent perforators.
Yes.
But if you have, because if you have incompetent perforator, even if you treat superficial, the reflux, the deep system is going to affect your skin. So you have to close these perforators. But so if you have both, you just treat the superficial venous system plus the perforator if you have an ulcers. If there's no ulcer, you just treat the superficial system. For the perforator, the only perforator we treat is if patient is around the ulcer or at the base of the ulcer. But like if you see perforator in the mid of the thigh, I will not treat it.
Yes.
Okay, so we just treat the perforator who transmitted the high pressure from a deep superficial system in the ulcer or around the ulcer. Any ultrasound you see, guys, tell you incompetent perforator away from the ulcer, leave it alone, don't deal with it. Okay.
Okay.
Yes, I agree that some people they wait for 3 months, but in my opinion, this is wasting of time. Why you have to wait for 3 months? I mean, you already know the problem. You know what the cause of that. Well, I don't know why you have to wait for 3 months. I know this is what they said in the book, but I will not agree with that. Again, guys, remember, whenever you read anything, this is somebody's opinion. Doesn't mean that you have to follow that. If a patient came to me, I already have a reflux, positive reflux, already has a venous ulcer. Yes, I'm going to do 4-layer compression, but I go and treat his saphenous vein right away, the incompetent. And if any perforator, I go and treat them around the ulcer. Okay?
Yes.
But what you answer is okay with me. I have no problem with that. I'm not to fail you for that, but it's a different way to do it. But if you tell me also I go right away and do it, I don't think it's wrong. Okay?
Okay.
After 3 months of free compression therapy, she presented with no significant improvement. So so what's your next step? As you said, you go and close the saphenous vein.
Yes.
So I'm going to use which one? We have different things. We have a thermal and we have non-thermal.
Radiofrequency ablation we'll use.
Use radiofrequency because you got used to it. Okay.
Yes.
What about non-thermal, like what called
VENASEAL and VENASEAL.
VENASEAL.
Yes.
So when you decide to use thermal, non-thermal, what's the difference? May ask about question about what's the difference?
If the patient if she has any known allergy to any materials like contrast of VENASEAL, something like that, I will go for radiofrequency ablation. And radiofrequency ablation, as I read it, it has the highest rate of non-recurrence among the VENASEAL and also laser ablation. So
no, I will not agree with that. I think laser has the least recurrence rate. But you see, the recurrence rate is 1 to 2%, so it's not a big difference. I mean, recurrence rate is about 2%, 3%. So one of them like 1% recurrence, one is 2%. So yes, the least one is really the laser, but it's the most dangerous one because you have no control. You have controlled very well. With radio frequency, it is more friendly,
yes.
Use. VENASEAL, it has advantage. You don't have to care.
Yes.
Okay. But the most important.
Yes.
Yeah, go ahead.
The advantage of VENASEAL, we will not use tamoxifen injection in contrast with radiofrequency ablation and laser, and the technique comparing the VENASEAL and the radiofrequency ablation and laser. The VENASEAL, I think you should keep a space about 5 centimeters from the saphenofemoral junction, and the radiofrequency ablation and laser 2 centimeters. I think it will be enough.
Correct. Even though now some people they challenge that, they go all the way to the junction with the laser. But again, it's not our discussion now. But some people they go all the way flush, but has some risk. But again, the exam just be on safe side. I will be at least, as you say, 2 centimeters from the junction. Okay.
Yes.
But the most important, you didn't answer it for me, is what's the difference when you decide to do thermal or non-thermal? The most important two things: below knee or above the knee.
Yeah. Yes. That's first of all, the skin, the depth of the vein from the skin. If it is less than 1 centimeter, there is a high risk of burn injury. The other thing, the tortuosity and the size of the vein. This is all measures that go from ablation rather than ligation.
Okay, let's talk about tortuosity. I never in my life saw a saphenous vein tortuous. When you see tortuosity saphenous vein, this is not a saphenous, this is a branch, because saphenous vein is always straight. So when you see any kind of tortuosity, most probably the saphenous vein is occluded, and this is just a branch of the saphenous vein going under the skin and all tortuosity. Okay, so and your saphenous vein is deep. When you see it going all very, very superficial from the skin, most of it is a branch of it, or he branch and goes up. But anyway, so the difference when we do thermal or non-thermal, as you said, it's very close from the skin, then the thermal could be injury unless you could put a good tumescent. So it's better to use non-thermal. But also the disadvantage of non-thermal when patient is very thin is that the patient is going to feel like a lump under the skin. because
Yes.
in the non-thermal, it's called thrombophlebitis because you thrombose the vein. It's not you dissolve it. So he's going to feel like a cord under the skin, and he's going to get a thrombophlebitis. So there's going to be a lot of redness and pain. So everyone has advantage and disadvantage. It's the way you have to decide. The second thing, if you have to go below the knee, if the reflex going very far below the knee, you cannot do saphenous vein below the knee with a thermal because you can damage the nerve. But you can do venous seal. So if you have to go really distal below the knee, then it's better to use a venous seal. If just above the knee, you can choose whatever you want, and as far as you know what your plus and minus for each one, you know.
Dr. Samir, one question. I think in the radio frequency ablation, we decrease the thermal efficacy when we go to the below knee. It is also cause a higher risk of nerve damage because the frequency in the thigh should be changed when you go below the knee.
Right, but you see, all of them, they create a heat, right? So, I mean, you have to put a tumescent, but if you don't put enough tumescent, the problem with the nerve become very close to the vein below the knee. So there's high chance to damage the vein, you know? So it's not really recommended. So if you don't below the knee, either use a thrombolysis, you use a venous seal, or you can use a foam therapy or sclerotherapy. This is easier. Just do foam therapy. But don't play with the heat below the knee because you end with the problems and, you know, and remember, I mean, this is a venous ulcer, it's different, but patient comes with a varicose vein, the expectation is very high. It's different from the patient comes with a critical limb ischemia.
Yes.
Patient comes with a critical limb ischemia, he's more concerned to save his leg. People that come with a varicose vein, even small discoloration is major for them, you know. So imagine you burn the nerve and they end with numbness. They will kill you, you see. It's not an important, but for them is a major. So you have to be very careful when you deal with the saphenous vein, with the varicose vein. When you deal it for ulcer, it's different because patient is really frustrated. He just wants to have ulcer to heal, doesn't care about nerve damage or whatever. But when you do it cosmetic, it's different. So you have three options. Everyone has plus and minus. Just pick up what is the best for the patient. Sometimes the price make a difference. Some because one is more expensive, you know.
Yes.
So because all of them, I don't think is major different. If any major different, would be like 3 to 4% in recurrence, which is not a major things. Especially you do it cosmetic. It's not like you're doing major procedures. It's not like it's going to lose a leg if it's open up the vein. So I think recurrence will be my least concern. My main concern is comfort for the patient. Which one you get used to it? One with a less complication, less pigmentation, less burning to the skin. Yes. You know, I thought I'll look for it. Prices also, it's not fair for somebody like paying out of his pocket to give him like venous seal. They have to be like 20,000. Where you can do it with a radio frequency is 5,000. You see, all that have to look for them. All this, you know, take him in your consideration.
Yes.
All right. So patient want to hear her option. We talk about it. What is common reasons that surgeon would recommend non-thermal instead of thermal? We said above knee, below the knee. Is there any cause where either of this would be recommended? Are there any causes where neither of this endovascular category would be recommended? Is there any place where none of them you recommended?
Yes, in case of the saphenous vein is more than 2 centimeter, very aneurysmal or huge.
Yes, we have a huge.
Yes, he's asking about the indication for ligation. It's a case.
Yes, that's correct. So if the vein is more than 2 centimeter, then endovascular will not work. Then you do a surgical stripping. Okay.
Yes.
Okay. The patient is deep with the saphenous fascia throughout its course and has size 8 millimeter throughout. Which type of ablation would you recommend? You said radio frequency, right?
Yes.
Describe the procedure. Go and describe to me.
Yes, the patient will be in supine position and with the reverse Trendelenburg position. And after draping a sterilization of starting from above the groin until the whole leg. Then after that, I will using ultrasound guidance to puncture of the great saphenous vein. Usually, I will do it. Usually, I'm practicing to do it below the knee if the saphenous vein is enough. So I will access the saphenous vein, and then after that, I will insert the sheath, 7 French sheath. Then I will insert the probe of the radio frequency. Then I will recheck my position and I'll make sure it will be 2 centimeters from the saphenofemoral junction. The probe, the laser probe, to make sure it is not going up to the junction or below. Then after that, I will start injection of the tomosine, all the course of the saphenous vein, and make sure it is cover all the area below the saphenous fascia, and make sure to keep it away from the skin at least 1 centimeter. Then after that, I will start. I will recheck again for my position of the radio frequency to make sure more than 2 centimeter. Then we'll start ablation. When I reach to the area below the knee, I usually decrease the frequency, as you mentioned, Dr. Sam, risk of the nerve injury. Then after that, complete the ablation, and we'll do the compression after that.
Yeah, you forgot one step, which is very important.
Recheck the saphenous vein after the
No,
ablation.
you need to do compression ultrasound.
Yes,
It's very important. When you finish, always do an ultrasound, be sure it's no DVT, and ensure the vein is ablated. So always, when I finish, you get the ultrasound is already there in your hand, it's in your field. So just go look at the verticamo-femoral vein, be sure it's no clot there, it's compressible, because this is very important. This document that, because patient get DVT, then it's not your problem, because you see after procedure, maybe she got DVT for other reason. And so this one, be sure it's compressible, with biphasic flow when they do, during respiratory changes during respiration. And then you look at the saphenous vein and be sure it's no flow in saphenous vein. So you document this both, okay? And then you put your compression dressing, okay?
Yes.
When you do tomosine, be sure it's around it. You cannot just put it on the arterial or posterior wall. It has to be around it. It has to be a circle. Otherwise, you get a burn. So you have to be, it has to be cold. It's very important. It can cause spasm. All right. On the follow-up, there is a thrombus extending to the common femoral vein, obscured 50% of the lumen. What do you do?
This is EHIT type 3. And in such cases, I will start her for therapeutic anticoagulant.
Okay. For how long?
For 3 months.
Okay. And what do? You repeat the ultrasound when?
I will repeat ultrasound after, I think you'll repeat ultrasound after one month.
2 weeks.
2 weeks,
Maybe
yes.
less 2 weeks.
Yes,
to
make sure there's not,
because this is, because it's a thermal injury, because you see,
yes.
So you have to be sure it's not getting worse. On follow-up, CAT scan clot was retracted and now flush with the saphenofemoral junction. So what do you do
So
now?
in such a case, we can stop the anticoagulant. Such a case,
Can stop.
if the follow-up duplex is more than 3 months, so we have to complete the course of anticoagulant 3 months. And in this case, I will stop the anticoagulant.
Okay. What if the initial venous duplex showed a perforator proximal to the ulcer that has 4 mm in diameter with a reflex 1 second? Would you have changed your approach?
No, anyway, I have to treat the gasophagus first. Then after that, I will deal with the perforators. In such a case, a perforator 4 mm with reflexes 1 second is considered pathologic. It should be treated as well. As you mentioned, Dr. Samer, if it is close proximity to the wound or it's over wound, it should be treated. The options of treatment either to be a avulsion of the perforators or maybe by sclerotherapy injection. So in such a case, the perforator is pathologic and near the wound, I have to treat it.
Okay. Some people, they wait for 2 seconds, I think, to come really pathological, 1 time is not enough, but I agree. I think I'll go and treat it anyway. All right. Any more question? Here. Over the course of 3 months, the patient goes on, heals the wound and asks if there's anything else need to be done to make sure that she doesn't. Can't read it. Can you read it?
Yes, over the course of 3 months, the patient goes on to heal the wound and ask if there's anything she needs to do to make sure that wound doesn't
come back.
Yes, I will advise to continue the compressive and the elastic stocking because still she has reflux in the deep system. So my advice for her to complete the elastic stocking.
All right. But if you only remove the saphenous vein, why the ulcer will recur? Do you know why?
Recanalization, one of the options.
No?
And the other thing,
The perforator may become incompetent,
yes,
because she has perforator, maybe competent, maybe after a while become incompetent, and then the ulcer come back. Okay, then you have to
yes.
treat it. All right, I think you did good. I think we're done.
Thank you.
Was there any question about the venous system, guys? Any question? Any of the cases? We did 3 cases: 1 DVT, 1 PE, 1 is venous ulcer. I think this is the 3 common scenario. I'm going to
Yes.
ask you about them.
السلام
Samir?
عليكم حسين.
Yeah, go ahead, please.
Yeah, if you have a patient who's having reflux in the great saphenous vein with multiple refluxing perforator in the thigh and leg, but he doesn't have venous, is treating the great saphenous vein enough, or you need also
Yes,
to intervene
yes.
for the perforator?
No, just get some vein is more than enough. You don't need to deal with the perforators. Okay, because perforator, the moment you get saphenous vein, perforator has no effect. The only effect the perforator when they are in the deep of the ulcer. But when you close the greater saphenous vein, all this perforator will close because no place to get out, because disconnect the greater saphenous vein with the deep system. So I don't think, if it's no ulcer, I will not treat perforators.
Okay, thank you.
Any question?
السلام عليكم حسين.
Alaikum salam, please go ahead.
Please, I want to ask if we can use a great saphenous vein as an axis for thrombolytic therapy if the thrombus is isolated in the iliac.
I mean, you can use it, but why you need to use it? I can go to femoral vein, it's easier, or vertebral vein, depending where is the clot. If the clot only in the iliac, femoral vein is much easier, bigger and easier than to go through saphenous vein. But practically, yes, you can go any place. You just need to get an access. So yes, I mean, if you don't get, you can go through the saphenous vein.
Okay. طيب, last year the examiner was asked me what is wire flossing test.
What do you call it?
He was asked me what is the wire flossing test.
Flossing test. Flossing.
Yes.
Flossing through and through. What do you talk about? What was the method? What was the scenario at that time?
Central venous occlusion.
Okay, and what are you talking about the wire?
He was asking me what is a flossing test, flossing technique, or flossing wire. I think that same like this.
I don't know, but what I know, flossing, when you go from one side to the other side, like through and through, like we use that when you have like angulated neck in the aneurysm. We get the wire from the femoral all the way to the brachial, and you have wire from both sides, so you can push it. So you have through and through wire. I think this is something, but I have no idea. What I was saying, the exam, some people, they read something and they come with it. I don't know if anybody has an idea, I can answer.
Thanks, boss.
No problems.
Hello,
Yes.
I think
What's
philosophy
that?
technique in the CPO, when you don't able to cross the lesion from the transfistula, then you can use another axis from femoral, and you do snaring from the wire to the other side.
What I'm saying, so the same idea. You get from both sides, through and through technique. Yeah, this is the same idea. What we call through and through technique. You get from one side to other side, and then you pull from both sides, and then you can push things. You know, again. So the same idea. You go from femoral, you snare, you get from other snares. So you have from both sides, and then you can push it. But what's the advantage of that? I mean, we use it when you have an angulation where you cannot like push through it. Sometimes we use it in the lower extremity. Like sometimes you have a wire can go through like a tibial arteries, but the artery very calcified. You cannot get the wire. You can't get the balloon through it. And this, you can see that many times, especially with a calcified artery. So what you do is that you get the wire all the way to the side of its artery, and then you put a needle and you get the wire out from the bits artery all the way to the skin outside. So now you have a skin out from both sides. And then at this time, then you put a hemostat at the entrance of the balloon with the wire, and you pull the wire down. So when you pull the wire, it pulls the balloon through the stenosis, and then you can balloon it. This is the same called through and through wire or flossing technique.
Okay, thanks, boss.
Okay, any other question? Let me ask you guys a question. I think it's important for thrombophlebitis. How you treat thrombophlebitis? Because they may ask you in the exam. Anybody knows?
By using
And do we give?
Yes.
Hmm?
By using yes, using the non-steroid anti-inflammatory and cold and warm compression, and I think.
Do you give anticoagulant?
No. The superficial thrombophlebitis, it's considered depend on the extension of the superficial thrombophlebitis. If the lower limb more than 10 centimeter segment and less than 5 centimeter from the deep system, I will consider therapeutic anticoagulant. Otherwise, no, I will not give anticoagulant.
So you said more than 10?
More than 10
than 5.
length, less than 5 from the second femoral junction, yes.
It's very close, the number. I mean, you're getting very close. Well, you know what the name of the trial?
I'm not.
Callisto trial.
Callisto trial, here we are. Here, well, Bara, okay. Bara. So what the Callisto trial said? What's the right number? He was very close. What's the right number?
More than 5 centimeter.
Correct.
In
and
the
less than?
I think also 5. Yeah.
No, 3.
3
less
from
than
the,
3.
From the deep system, and anticoagulation for 45 days.
Correct. So less than 3 and more than 5. We have to do both. I mean, if like more than 5 in the middle of the thigh, we don't give anticoagulant, correct? So it has to be both, less than 3 centimeter and more than 5 from the second femoral junction. But if you have like thrombophlebitis in the middle of the thigh, like 10 centimeters, I will not give anticoagulant.
Guidelines said if more than 10 centimeter in the thigh, or less than 3 centimeter from the junction, I will go prophylactic anticoagulation.
Yes, but not 10, it's 5. Anything more than 5 and less than 3 centimeter from the junction, you have to give anticoagulant for 45 days.
It takes 2 procedures. I think if it is more than 5 and less than 3, full anticoagulation, and if it is more than 10 and less than 3, prophylactic anticoagulation only, not full anticoagulation.
What medication you give?
If full anticoagulation, low molecular heparin weight, and if it is prophylactic fundobronix, I forget the dose. Fundobronix.
I mean, look, I don't think we have like something prophylactic and treatment, because both we give them as prophylactic, because it's not a DVT. So you're treating all of them as prophylactic. So I don't think we should differentiate between therapeutic and, because therapeutic, you talk about DVT, and here we don't have a DVT. We're doing it is prophylactic. So anything, again, less than 3, more than 5, I think we have to give parenix. What is the dose and for how long? It's important, guys. They may ask you in the exam. How long and what's the dose?
2.5.
2.5 for 45 days.
Sub-Q, correct? For 45 days. Okay?
Yes.
How does Funda Parenex work? Anybody knows? Which level of anticoagulant work? Anti what? Which factor?
Factor 10A.
10A, correct. Why we don't give heparin or low molecular weight heparin? Can you give heparin or low molecular weight heparin or rivaroxaban? No. According to this trial, it's not like you cannot, but we don't have evidence. This is the whole idea. It doesn't mean you cannot. But the evidence in the trial showed only that when the Parenex is you give 2.5 milligram sub-Q for 45 days. For heparin, subacute heparin, or Clexane, or low molecular weight heparin, or rivaroxaban, all of them, we don't have enough data to tell we can use them or not, so we're not sure. But the other one, we are sure. What the advantage of fondaparinux over the heparin, low molecular weight heparin, it works on factor 10A, as you said, so it does not interfere with the fibrin. So will not cause bleeding. It will not interfere also with the platelets. You don't see like a hit with the fondaparinux. So two things is that will not interfere with the platelets, does not interfere with the fibrin, so less chance of bleeding and problems. The reason why they advise to use it. All right. Of course, plus you use warm compression and anti-inflammatory medications. All right. I think we're done with the venous system. Any question about the venous system? With the venous system, guys, always IVUS is very important if you do chronic. Venogram is useless. So if you want to see any compression or sizing or anything, we don't size on CAT scan. We don't size on the venogram. All we size on IVUS. If you have a May-Turner syndrome, you have to size it. You size the vein before and after, and then you get the average and you put a stent. When you do a stent, it's very important to be a long stent. Don't use short stent. We don't use short stent in the venous. It should be at least 60. We don't use 20 or 40 in the venous. Even if the compression is very short, we don't, because this stent would come jump all the way to the heart. So you need to fix the stent. And oversize is very important because you see vein, they change different from the arteries, change their diameter depending on the volume of the patient. So in the iliac, always use like 16, external iliac 14, common iliac 16, 18, IVC 20, 22, but don't use like 12 in the common iliac. You see? So always use, again, at least 60 length and above, and at least, size, again, external, I will go with a 14 or above. Common iliac artery, I'll go 16 and above. IVC, I'll go 20 and above. What else? You have to know.
So, Samuel, I think there is something.
Anticoagulant is no protocol for anticoagulant. Most people, they do anticoagulant. We don't give antiplatelets. They don't work in the venous system. So give anticoagulant at least for 3 months or 6 months or even 1 year. And after that, you can change to antiplatelets, but at least the first year. When you put a stent, the most thrombosis happen the same day of the procedure. So when you do any stenting in the venous system before discharge patient, you have to do a venous ultrasound the same day or next day morning, because this is the time when it stents thrombosed. So always before you take, because thrombose, you can very easy to do, thrombectomy, thrombolysis. If you ask him to come for 3 months and then stent being thrombosed for a month or 2, you don't know, then be very difficult to thrombectomy. So again, always do ultrasound before patient discharge. What else? Always use a venous stent. Don't use arterial stent because it's completely different, design. So it's not recommended. You can use it, but it's not recommended to use it. Always use self-expandable stent. We don't use balloon expandable stent in the venous system, except in the tumor. If you have like a tumor compressing superior vena cava, then we use a balloon expandable stent. But anything else, we always use self-expandable stent.
Dr. Samer,
okay, but now you can talk.
Yes. Sorry. Built-up technique. I'm not sure if it is starting from distal first with a smaller size, then go up with a larger, right?
Yes, and yes, of course, you have to put the larger and the smaller stent. Yes, but again, I mean, the vena is not big different. I mean, even if 16 you put an 18, it's not a big deal, or 14 you put 16. It's not a big deal. You need a big really stent. But yes, if you're going to do, you have 2 different sides. Always start with the proximal, then go to the distal.
Sir, I want to ask. Finished? Sorry.
Go ahead.
If you want to shift between duct or warfarin, or from duct to duct, or from the warfarin to duct, what's the conclusion?
Talking about the arterial or venous system, we're talking about in general.
Yes, definitely.
Okay, you know, warfarin takes at least 2 days to clear out from the system. So it depends. Then sometimes you can just stop it for 2 days, or sometimes it takes longer, depending how his, you know, liver and kidney function. And sometimes you have to bridge it, and sometimes go ahead.
Yes, this is not and some people need to bridge from warfarin to DUAC, or from DUAC to warfarin, or from DUAC to DUAC. This is my question. Okay.
But what scenario? Why they do that?
Someone cheap,
Yes.
someone expensive. Ducks.
No. I mean, see, the only time we DUAC doesn't work in the DVT or thrombosis if you have antiphospholipid syndrome. This is the only one you have to give warfarin, then DUAC will not work. Okay, patient has antiphospholipid syndrome. Otherwise, DUAC I think would be the best first choice. If DUAC failed, then you can give warfarin. But I never heard about this bridging between warfarin, DUAC, warfarin. No, I never heard about it. But if there's no contraindication of the DUAC doesn't work, then you can give warfarin. Any other question?
Thank you, Dr.
All
Sadiq.
right. But was any question? You asked your question. I forgot. Do you ask your question?
لا قلت
Then
thank you
it's
بس.
fine?
Yeah.
No more question about venous system? All right. So next week, I think we'll do the AV access and hopefully we'll be done because the guys, they have an exam at the end of the next week. So next week we'll do an AV access. And then we'll be covered most of the scenarios, hopefully. All right, guys. Have a nice evening and go watch the game. I don't know who won. We should know by now. Who won? Morocco? Nobody watching. Okay, that's good. So it's me attending the lecture. This is good. All right, guys. Good night.
Yeah.
Good night. Take care. Bye-bye.
Salam alaikum.